So here's a case. This is a case of maxillary non-restorable dentition, extensive periodontal disease, and some decay as well. 56-year-old male. History of prostate cancer with metastasis to the spine, which was treated. Hypertension, which is under control. And he basically wanted to have new teeth for his daughter's wedding. As you can see, the extractions were done, debridement of the sites were done, leveling of the bone was completed, and the implants were placed. But now we've got these huge voids. And when you have a huge void, if you don't do anything to it like a socket, bone will eventually fill in. We know that from just extractions. If you take a tooth out, let's say even a third molar, I'm sure there's some oral surgeons like myself on this call. You take out a third molar, and you don't generally graft third molar sites. You go back for something else, you check a conium, you do a physical exam, you see that the bone generally fills in, especially in a four-wall defect. However, in a case like this, we have to close our incision sites. And when we close our incision sites, we're prematurely bringing soft tissue into the area. And we can have soft tissue ingrowth, and rather than bone regeneration, we can have connective tissue ingrowth, which would cause our implants to fail. So in a case like this, even though this is quote unquote, like I said, a graftless solution, we want to place something into these sites. Now, what I have traditionally done, and I've been doing full arch cases all on 4, all on 6 for my entire career. Traditionally, what I always tried to do was to use some of the autogenous bone that we procured during the leveling and reduction of the alveoli, and reuse the patient's own bone. Like I said, autogenous bone has always been the gold standard, and that worked pretty well. But sometimes we don't have enough bone from the patient. Sometimes we don't want to reduce as much as what would fill all these sockets. And if you look back at this this photo here, this panoramic X-ray, Mother Nature has already done a lot of the bone reduction for us. The bone reduction that we would have done, we don't have to do quite as much because of the periodontal disease. The bone reduction's already been done. So sometimes we need to augment the autogenous bone and use something else. So what do we use? Well, what I'm looking for when I choose something is something that's easy to use, handles well, and I'm not a big fan of needing to put in a membrane if I don't have to. One of the things that really drew me to the bone cement is that the bone cement itself excludes the soft tissue cells. So because of that, you can place the bone cement into these voids, into these big sockets that we have, and it'll form bone, as we've seen in the earlier cases so nicely. And the membranes don't need to be used, so I'm reducing time, I'm reducing cost. And we've also got the exclusion of the soft tissue at the same time. So the cement is actually working as a bone graft and as the best kind of membrane you can imagine. It also has some properties which are antimicrobial, which is also helpful, because when we're going into these cases, oftentimes the reason we're taking these teeth out is because of periodontal disease or decay. And so even though we're using antibiotics and we're using proper coverage, but now we've got a localized bone cement that has some antimicrobial properties. So this is really a unique position for the bone cements, where I think it outshines anything else that I've used, and I've used pretty much everything for these type of full arch cases.